Welcome back to another episode of School of Airway. Something happened recently with the cardiac arrest, and it's funny how we use terms in simulation that could be misconstrued. So if I were to say light them up, either light them up like on fire, which I'm not trying to mean, which I don't mean, or light them up like John Dillinger with the atomic gun, machine gun. No. If I see a shockable rhythm, I'll probably say, in a weird way, light them up, defibrillate them, shock them, right? So in the heat of the moment, if I say light them up, please don't misconstrue what I'm trying to tell you. It's sometimes a little entertaining and playful to say things like that, but if you do line them up, there are a couple things you need to know, right? Why you're priming the patient with CPR, right? And everyone gets away with this and have arguments with Dr. Sim, who teaches acls and is an instructor. Right? That just usually pretty good. And patients have come back. I know using two hands is best, but I'm trying to direct traffic, tell people what to do. You over there, get the line, get the Lucas. Right? It's easier to do with one hand, to direct traffic, or to turn to look at the monitor. Alright? And if the pads are happen to be on, guess what? We have gone to this habit of saying, I'm clear, you're clear, everybody clear. But guess what? If I am going to be the one doing the CPR, I should be taking the risk. And I'm going to tell you, I wear rubber-soled sneakers, shoes, and I wear gloves. And I've yet, in the past 18 years, be shocked, or get electrocuted, or fall out, pass out, and be in cardiac arrest from getting shocked while CPR is while it's happening, right? While I'm doing the CPR and you defibrillate, I do not pass out. I'm human. I'm not an alien. I'm not a different subspecies. I do not pass out. So I'm telling you, if you're even that nervous, right? Coordinate with the person that's about to shock. 1, 2, 3. The shock is that quick. Right? It could be a dance move if we want to. Right? But I'm going to tell you, I usually don't stop. Some people even advocate you wait just 2 minutes and feel for a pulse. Ideally, I probably would use an ultrasound. I look at the carotid to see if there's a true crappy pulse or pulse at all. The artery is more reliable in seeing there's a pulse than feeling for a pulse. I'm going to tell you straight up. And if you can't feel a pulse, most likely BP too low is PEA. Identify the cause. Hypovolemic from GI bleed. Above or below. Bleeding internally in the abdomen from a ruptured ectopic or perviscous. Pneumothorax, a massive tension pneumothorax, massive PE, massive MI, things like that. Okay? Some would argue, wait for the end tidal to jump from 10 to higher, 10 to like 30 or 40, and then you're like, oh, I probably should look at the rhythm. There are supposedly monitors are coming out that while you're doing the CPR, the artifact of the CPR causes a motion that the heart may not interpret correctly, and I can't interpret through. There's software that supposedly deciphers through that motion artifact and will tell you what the rhythm is underlying despite the motion artifact of the CPR. So, light them up can mean a lot of things. Light them up in this patient who's in cardiac arrest. Be tap, be fib. Either you practice your dance doing this to the Bee Gees, or my favorite, another one bites the dust. No one bites the dust. One hand, if you got the skills and the strength to do it, coordinate the care that's necessary, and then you saw that mini pause. That's all you need to light them up. And for those who believe in me, guess what? You can still do it. Light them up and keep on going. I'm still alive. PGY 18, still kicking and working. Please come back to another episode of School Highway. Bye-bye.